Hi, my name is Dr. John Rundback from New Jersey Endovascular and Amputation Prevention in Clifton, New Jersey. It's my pleasure to present to you today this case of a limb salvage procedure, going the distance, making a difference. This patient is a 55-year-old mother of two teenage children with long-standing type 1 diabetes, high blood pressure, elevated cholesterol, and a kidney transplant. She had prior hemodialysis as well for diabetic renal failure. She has known extensive peripheral arterial disease with blockage of the arteries of the lower foot and leg and prior toe amputations. She now presents to us with non-healing left plantar calcaneal wound and a very painful wound on the left fifth toe, as well as a painful wound of the right fourth toe, all of which have been present for 4 months. Prior to seeing us at American Endovascular and Amputation Prevention, she was told that no further procedures were possible to restore blood flow and that she would need below-knee amputations. Here you can see the pictures of these wounds, which extend down to bone at almost all levels, particularly when probing, and are very deep wounds, which is why amputation had been recommended. Based upon the findings of the examination, as well as our arterial imaging showing that she had extensive diabetic tibial occlusive disease, our plan was to perform angiography to target and treat the wound-directed arteries, what we call the woundosome or angiographosome, and doing multiplanar angiography with wound markers to make sure that the optimal arteries supplying the wound are identified and treated as possible. This requires that we perform interventions to restore blood flow in the arteries at the ankle and below the ankle and in the pedal arch as appropriate to revascularize obstructions in the very distal arteries typical of a diabetic patient such as this. In this example of the procedure on the left foot, you can see where the wound is, and when we do an angiogram through the artery over the top of the foot, the dorsalis pedis artery, we see that there's flow to the inside, the medial aspect of the foot, but hardly any blood flow to that lateral compartment in the foot. We were able to take a microcatheter through that portion of the foot, through that pedal arch and out to the lateral compartment of the foot, and then perform 1.5 millimeter angioplasty through the plantar pedal arch, as you can see here. This balloon is so small you can barely see inflated through the obstructed segment. After performing angiography, you see markedly increased perfusion and restored circulation to the lateral compartment and to the areas of the wound, as indicated by the arrows. 2 months later, this patient has complete healing of this wound, which was considered an unhealable wound with a pattern of arterial blockage, which was not felt to be amenable by other operators to intervention and repair. I think the lesson learned here is that treating patients with critical limb ischemia requires a team with extraordinary commitment and diligence and a willingness to treat those smaller arteries, those very small targets at the ankle and in the foot that are not usually addressed by most people who perform vascular intervention. These arteries are not amenable to surgical bypass due to their very small diameter, the fact they often have calcium, and that they're very small and in the foot, and you cannot connect bypasses to them. However, with this diligent approach and with careful ongoing care, major amputation, as in this patient, can be prevented in more than 80% of patients, even when they've been told that limb loss is inevitable. Close follow-up and continued vascular care, in combination with wound care and medical management, preserves limbs, and we like to call this toe and flow. Together, we can make a difference, as we did in this patient. Thank you.